Hi everyone, my name is David Villar. I work as a professor of pharmacology at the University in Colombia. Welcome to this presentation on local anesthetics, which are really a group of drugs that should be included in most protocols to provide analgesia. We're going to provide some examples of the different applications of local anesthetics, and for the most part, we could say that their value is largely underestimated, as they can provide almost complete analgesia with very little or no side effects. These are really the only drugs that totally block the transmission of noxious or painful signals into the spinal cord, and by doing so, they're going to prevent the process of central sensitization that we alluded in previous videos, and pain will be easier to control when the patient wakes up from an anesthesia. On the next slide, we're going to review some papers in which they use local anesthetics for each one of the applications listed here. The first one, infiltration. This is used basically to provide an incisional block, and sometimes relatively high volumes of the anesthetics are necessary, and that's the reason why we combine it with epinephrine. So the duration of action is prolonged, and the drug doesn't go into the bloodstream so rapidly. Now, with regards to a splash block, this is when the drug is directed to the site of interest, for example, a root canal, when we do a tooth extraction, or adjacent to an ovarian ligament when we do an ovarichysterectomy. With regards to field blocks, these are the typical C-sections that you might have seen in cows. And when these are done correctly, we basically block all the nerve tracts that innervate an entire body region distal to the line of injection sites. With topical anesthesia, in this case, the drug must be capable of penetrating either through an open wound or the skin or a mucous membrane. You might have seen those Lidocaine creams that are used prior to placing an IV catheter. Epidural anesthesia involves the injection site, involves the injection of the local anesthetics in the space surrounding the spinal cord. The site of action is supposedly those spinal nerve roots, but maybe some of the drug can also diffuse into the spinal cord itself and have some additional effects that way. And finally, we can use the local anesthetics to provide analgesia with systemic infusions. And when these are done, these are usually combined with other analgesic drugs like opioids or ketamine. Here is the first example in which they use an incisional block with bupivacaine in dogs undergoing celiotomy or laparotomy, if you like that term better. There were 60 dogs that were randomly allocated to 4 groups that received either preoperative bupivacaine before the midline incision, postoperative before the skin closure, and these 2 were compared with 2 control groups that were given either preoperative or postoperative saline. The dogs, as you can see, also received the opioid meperidine. And the conclusion of the study was that preoperative bupivacaine was associated with significantly lower pain scores, and they used a numerical rating scale. And another finding was that there was a significantly lower need for opioid administration in the postoperative period. Now, an important thing is that these local anesthetics, when they're injected into a wound site, they don't delay healing, which is a concern that maybe some veterinarians may have. So they can rest easy that this is the healing process is not really affected. Now the next study, this one again reinforces the concept of giving the drug before the surgery, and also the interest of using different ones to attain what we call a multimodal enhanced effect. In this case, the positive control was using epidural administration of morphine, which probably nobody uses for male castrations. And in this study, the 2 groups that received either the epidural morphine or the intratesticular bupivacaine had much lower postoperative pain scores than the dogs that receive a combination of injectable opioids and the non-steroidal anti-inflammatory carprofen. And we could say that because the pain impulse was completely blocked in the intratesticular group, the brain was not realizing that the spermatic cord was being crushed. And crushing injuries are really very painful, probably some of the most painful stimulus of any type of surgeries. And they also concluded that even the intratesticular group was superior to the epidural injection of morphine, which is kind of the gold standard. And the reason was that they found less dogs that required rescue analgesia. And they also had lower pain scores, and the level of cortisols released after the surgery was also lower. Now, in this next study, they evaluated the effects of maxillary and alveolar nerve blocks in cats undergoing dental extractions. All the cats received systemic buprenorphine, medetomidine, and acepromazine, and they used a composite pain scale before and for 4 hours following the extractions. The results were that pain during and after the extraction was lower in the group that received the local anesthetics, and also that during the surgery, the heart rate, the blood pressure, and the minimum alveolar concentration of isoflurane that was needed was lower in the group with local anesthetics. And these are kind of an indicator that the animals were not really feeling the pain during the extraction procedure. Obviously, if you don't apply the local anesthetics, those cats will still feel better after 3 or 4 days without having all those painful teeth. But the question is that in the meantime, they're going to be quite painful. So this type of studies again reinforce the idea of the importance of providing as best preemptive analgesia as we possibly can. Now, an interesting application which many veterinarians are probably not aware of is using the local anesthetics diluted 1-on-1 with saline to irrigate the peritoneal cavity in dogs that are undergoing ovarichysterectomy. In this case, they instilled the local anesthetic, bupivacaine, after the surgery was completed. And basically, they were comparing these animals to a control group that also received opioids and non-steroidal anti-inflammatories. So the bottom line was, how much are you enhancing the analgesia by using these local anesthetics in the peritoneal cavity? This is actually widely used in human medicine, and in this case the conclusion was that the bupivacaine group, which is longer lasting than Lidocaine, provided significantly lower pain scores compared to the saline and the Lidocaine group. This is, as I say, is something that is usually not contemplated in most ovarichysterectomy protocols. And as you can see here, it's an application of the local anesthetics that veterinarians should be doing more frequently. One of the issues of applying infiltration analgesia is that sometimes very high amounts of the local anesthetics are necessary, and if they were to be absorbed rapidly, there is always the risk of creating toxicity. So you may come across formulations that combine the use of lidocaine with epinephrine, and this is one of those studies in which they look at the impact of adrenaline on the kinetics of lidocaine injected in the paravertebral brachial plexus, which you may need to do if you were to amputate the front leg of this dog. So they injected eight dogs with the usual 2 milligram per kilogram lidocaine at the spaces of the C6, C7, and the junction of C8 and T1. And then they collected blood to measure the concentration of lidocaine for the next 3 hours. And what they found is something similar to what you might see on this graph, which is actually I took it from another study, and I just wanted to illustrate the point of flip-flop kinetics here. When you use adrenaline combined with lidocaine, basically you are slowing the absorption rate of lidocaine, so you don't really reach such high concentrations of the drug in a short time. and consequently there is less potential for systemic toxicity. And in addition to being safer, you also prolong the duration of the local anesthesia because the lidocaine will be at the site of the injection a lot longer. So as you can see on this graph, the decline or the elimination of part of the lidocaine curve is less pronounced because lidocaine is being slowly absorbed from the tissues. Now, another way of looking at the multimodal effect of analgesic drugs is looking at how much of the gas anesthesia is necessary during an intervention. So in this study, they use a combo of lidocaine and ketamine and compare it with each drug given alone. And as you can see on the lower graph, the combination of the two drugs decreased the minimum alveolar concentration of sevoflurane by almost 62%. Notice that both drugs were initially provided as a bolus, and then they were followed with a constant rate of infusion. And this is basically done to keep the concentrations steady during the entire anesthetic period. On this other study, they used a computerized pressure algometer to determine the pain threshold in dogs that were subjected to a pressure stimulus. And the idea was to determine which concentrations of the ketamine and lidocaine will raise that threshold level. This was a crossover study with 6 dogs, and the 3 groups were given either a bolus of ketamine followed by a CRI, or a bolus of ketamine and lidocaine followed by CRI of both drugs, and a group with a bolus of ketamine followed by a higher dose rate of ketamine of 50 micrograms per kilogram per minute instead of the 30 micrograms per kilogram per minute. So if we look at the results, they found that the minimum serum concentrations of ketamine that produce analgesia were between 100 and 200 nanograms per mil, which is similar to what is found in humans. But unlike humans, dogs need a higher constant rate of infusion to attain those concentrations. So this is a good example why you cannot always extrapolate doses from one species to another. At the higher CRI of ketamine, the dogs also develop some of the anesthetic effects of the drug, like disorientation, swaying of the head, salivation, hyperactivity. And the most interesting thing was that when they brought lidocaine on board with the lower doses of ketamine, not only they produce similar nociceptive thresholds as the higher concentrations of ketamine, but they also prevented the side effects of ketamine. So the analgesia effects were very short-lived. As you can see, they disappeared within 20 minutes of ceasing the constant rate of infusion, and obviously that's the reason why they need to be constantly infused. And the conclusion of this study that was all 3 treatments increased the mechanical threshold for pain, and therefore they provided anti-nociceptive effects, but also that the addition of lidocaine was recommended to attain a multimodal approach, which is always a better way of controlling pain. Now, as a final slide, there is always a controversy as to whether lidocaine should be used in cats or entirely avoided. It seems to have a bad reputation, but when you search the literature, it doesn't really suggest any particular sensitivity of cats compared with other species like dogs. The rationale is that CRI of lidocaine causes more pronounced cardiovascular depression than equipotent doses of isoflurane, and that normal doses that are used in infiltration and blocks could potentially kill a cat if they were given intravenously. And this is not really the case if you don't really exceed the therapeutic doses, which are usually below 10 milligrams per kilogram. If we look at this study, in which they compare the central nervous system and the cardiovascular toxicity of lidocaine and bupivacaine in cats, they were infusing actually a very whopping dose of up to 16 milligrams per kilogram per minute, until the mean arterial pressure dropped to 10 millimeters of mercury, and they call that the cardiotoxic endpoint at which they started resuscitation protocols. And I'll have to say that they were successful resuscitating all the 10 cats, and they concluded that the mean convulsive dose was 12 milligrams per kilogram, which is about 3 to 4 times lower than the cardiotoxic dose. In other words, you may see tremors and convulsions before you see major changes in heart function. Now, if we look at the more common scenario in which you use lidocaine as an IV bolus and you follow it with a CRI, which is what was done on this other study, they found that lidocaine causes a dose-dependent decrease in isoflurane requirements. They went from a steady concentration of 1 to 10 micrograms per mil of lidocaine, which is really what you want to achieve as part of a balanced anesthetic technique. And basically at the higher concentrations of 10 micrograms per mil, there was a 59 reduction in the minimal alveolar concentration of isoflurane that was needed to anesthetize those cats. And when they look at the encephalographic recordings, they found no activity suggestive of seizuring or convulsing. Now the problem is that you need to lower those concentrations of isoflurane that you are providing, because if you don't do so and you are combining with lidocaine with isoflurane, you will definitely cause severe cardiovascular depression, and at that point you'll probably have to discontinue giving both drugs and initiate supportive measures. So it is important to keep in mind that if you plan to use typical isoflurane concentrations, you may want to avoid using lidocaine altogether. This was my final slide. We have tried to cover a lot of information in a very short time. I hope you enjoyed the presentation. So until next time, bye-bye for now.